Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
Good morning, everybody. On the 25th year of Lymphatic Education and Research Network anniversary, I am honored to present, I think I may have lymphedema. Now what? So I will go through different kinds of pathology and give you some information about swelling, predominantly of lower extremities. I am a clinical and scientific advisor for Vita Support. And thank you very much for all the support from different companies. Different types of swelling, and I am focusing predominantly on lower extremities. These are slides of my patients, and with their permission, I will guide you how to diagnose lymphedema. From the definition, International Society of Lymphology and consensus coined lymphedema as an external or internal manifestation of the lymphatic system insufficiency. In sense, what it is, it's a delayed transport capacity. To diagnose, we have to go through detailed history. Onset of swelling, when did it occur, what are the symptoms, and then clinical presentation and truly an inspection, physical examination, measurements, and then diagnostic testing. From the history, we have to also assess other pathologies. Are there any systemic diseases which contribute to swelling? Predominantly cardiac problem, hepatic problem, or renal insufficiency, and others. From the history, when was the onset of swelling? Did it occur at birth or later on, and what was the cause? We do see babies with lymphedema, and usually either they are born with one leg more swollen than the other, or just one leg. And we call it congenital. When it occurs at the age of, before the age of 35 is lymphedema precox, and after 35 is lymphedema tarda. From secondary lymphedema, you're born with normal lymphatic pathways, and there is some problem where there is a disruption or obstruction of the lymphatic pathways. And most commonly, we see it with surgical intervention and combination of treatments, chemotherapy, radiation treatments, and so on, or post-infection lymphedema. The most common cause, and I will guide you through more pictures, clinical presentation of congenital lymphedema, and as you can see, this little baby has right lower extremity involvement. This small middle picture shows you bilateral swelling if you look at the dorsum of the foot. These are congenital lymphedemas. This gentleman was 60 years old when he came to see me for the first time. All his life, he thought that he was better than anybody else because his legs were bigger. And so he was actively participating in sports games and soccer and so on. However, later on, every few months, he ended up in the emergency room where he was treated with steroids for lupus-like syndrome. Well, further investigation pointed out that he had primary lymphedema tarda. This young lady, and this is a typical scenario where you have young girl or predominant, more frequently girl than boy, she played soccer and twisted her ankle. That injury followed by swelling of the ankle and dorsum of the foot. And then there was a progression of swelling. And for about 1 year, she was going through all different kinds of testing, and nobody coined the diagnosis of lymphedema until we clinically examined her and compared it with lymphoscintigraphy. And I will go through lymphoscintigraphy findings later on. This young boy was 11. He was fine until the age of 11. And mosquito bite created swelling, gave him the onset of left lower extremity swelling with progression. And I have more study on him later on. Secondary lymphedema, the most common cause of lymphedema in the world, with estimated 40 million individuals in the world, is filariasis. And filariasis, unfortunately, this patient came to see us to the United States thinking that we have the magic pill. We don't. However, this is caused by Wucheria bancrofti in a bloodstream, and it usually settles in the inguinal area. And progression is severe. It occurs in tropical countries, predominantly where they walk barefoot through muddy waters and so on, and it enters through the skin to the lymph system. Secondary lymphedema, as I pointed out, is usually unilateral, as you see in this young lady with proximal swelling, or if it's bilateral, one lower extremity is more involved than the other. And if you look at this young lady, I have picture from the back, she was nipped by a horse and developed swelling without open lesion, developed swelling of left upper extremity. And she also has lymphedema in lower extremities. So when we did a further study, we found out she had insufficient aberrant anomaly of the lymphatic system throughout her body. Before, we used to see much more prominent upper extremity lymphedema secondary to breast cancer and a radical surgical adenectomy of removal of the lymph nodes in the axillary area with new intervention of sentinel lymph node sampling. And so we see much better outcome for lymphedema and not as very swollen. This also represents upper extremity lymphedema. A young man was a dentist, but with onset of the soft tissue cancer in the axillary area and radiation treatments, he was left with swollen, the entire right upper extremity dominant arm, and his hand finger dexterity was reduced, so he couldn't continue his job. Similarly, a young lady had breast cancer, and not only that, there was a progression and recurrence to the radial nerve, which left her pretty much paralyzed with the upper extremity lymphedema. And again, dominant arm. And this is a representation of lower extremity lymphedema, as you see, unilateral, and it's secondary to the bladder cancer surgery and treatments. Lower extremity, different shapes, different types. And again, inspection is very important. This young lady had swelling. If you look at both lower extremities, a dorsum of the foot is involved, stemmer sign positive, but she also had breast cancer. So all three limbs are involved, and it's challenging to manage this type of lymphedema, but she was very active and she did quite well. Lower extremity lymphedema secondary to adenectomy in the inguinal area, prostate cancer, and ovarian cancer, resulting in unilateral lower extremity lymphedema. Another slide what I want to point out is once we have lymphedema, we have to be very careful about the skin care and not open cuts and lesions. And if that happens, immediately wash it with alcohol swab or even soapy water to prevent any infections. And this is representation of cellulitis. There are different clinical presentation. Usually patient comes with feeling flu-like syndrome, chills, and which may progress. And this looks like little chicken pox with predominantly involvement in the axillary region. And this young man just had a surgery and developed infection following. So once that happens, or if you are traveling abroad, always take antibiotics with you, because a treatment with antibiotics will improve the problem, and cellulitis will resolve. Interesting article came from Dr. Dean and his team in his residential area, where they see chronic venous insufficiency, phlebolymphedema, more than 41%, 41.8%, and followed by cancer-related lymphedema, primary, and lipedema. I'm in Santa Monica, and initially I used to see more upper extremity lymphedema patients, and that was 2 decades, 3 decades ago. Then it progressed to lower extremity, and now, as of now, I would say we see good 40% lipedema patients. Secondary lymphedema patients followed after, and primary, maybe about 10 to 15% primary lymphedema patients and primary lymphedema patients. So I think it depends on localized area where the treatment center is, and accordingly you see the population of lymphatic disorders in your presentation. This young man had lower extremity lymphedema secondary to adenectomy in inguinal area and aortic lymph node, secondary to prostate cancer. Stemmer typically with lower extremity lymphedema, you have involvement of the dorsum of the foot, and the toes are like little sausages, and you can lift up the skin. From measurements, there are different centers are using different measurements. The traditional one is by ordinary tape, volumetric, tonometry, bioimpedance spirometries, and others. And wonderful articles were written about usage of a bioimpedance in measurements of the subcutaneous tissue. SOZO with LDEX is a wonderful way to detect in small changes in the fluid. And in our setting, and Delphin is very quick, only device which gives you very rapid detection of the lymphedema. And it's good to use before as a baseline and after completion of the trial of conservative management or others. From lymphedema, what are the clinical staging? Well, we go according to the International Society of Lymphology. Stage 0 is where there is no visible difference in the limb discrepancy, and it may improve over time, but the abnormal transport capacity is already present. Stage 1 is an early lymphedema. As you can see in this young lady, only proximal part is more involved. Stage 2, and it improves with elevation. That's the very important point. And for all lymphedema patients, whether it's primary or secondary, and we recommend elevation in conjunction with compression elastic garments. Second, stage 2 represents pitting edema, and it does not resolve with elevation. And stage 3, there are fibroadipose deposits and there are also skin changes, as you can see on this patient in corner. Lymphoscintigraphy is still the gold standard for detecting abnormality of the lymphatic system. And what we do is we inject a radioisotope tracer between first and second interdigital space, and we watch the migration of the tracer first 20 minutes, and then we ask the patient, if it's a lower extremity patient, to go and ambulate instead of being sedentary, because we want to see the uptake. And this is the outcome of normal lymphoscintigraphy for the total body. Injection and radiotracer goes to the inguinal area, lymph nodes, and periaortic lymph nodes, and axillary lymph nodes in the armpit area, and this is a liver. And the same thing is on the other slide. This young lady, as I pointed out before, her lymphoscintigraphy pointed out already that she had a reduction of the lymph nodes in the inguinal area, and with the progression of the swelling, and she already, when she came to see me first, she already had one bout of cellulitis, which was untreated, unfortunately, and a result is visible where you have extravasation of the traces, so the protein molecules are seeping into the tissue, and this what we call extravasation of the tracer or dermal backflow is present in the involved site. With this, we have to make sure that the patient is taking impeccable care of the skin, so the cellulitis will not repeat, because these patients are prone to infections more quickly. For the upper extremity, also lymphoscintigraphy points out on the side of the surgery, she had lesser number of lymph nodes, which correlates with clinical presentation. With Dr. Glass, we did a study where we correlated the clinical presentation of lower extremity lymphedema with lymphoscintigraphy. And we found out, yes, indeed, the clinical presentation, the lymphoscintigraphy complements the clinical presentation. This young lady had cervical cancer, and with that already, with the adenectomy of the lymph nodes and also radiation treatments, lymphoscintigraphy showed extravasation of the tracer into retroperitoneal area, excuse me, which gave her rise of abdominal swelling. This patient, unfortunately, she was a dancer. And similarly, through ovarian cancer, surgical intervention, she had bouts of dermatolymphangioadenitis, where you can see the erythema. What it means is inflammatory response with infection, where she has already erythema, increased skin temperature. And her clinical presentation is correlating with the lymphoscintigraphy. The lymph nodes were removed on the inguinal area, where you see the gap, and there is extravasation of the tracer into the thigh region. Similarly, patient with excision of the lymph nodes on the inguinal area and higher echelon lymph nodes higher up shows us complete extravasation, dermal backflow into the distal lower extremity, which correlates with the clinical presentation. And interestingly, this man had a bladder cancer, also adenectomy. The lymph nodes are missing on the involved side, And we have to be careful how we manage these patients, so the compression stockings are not going to be blocking the flow, as you see here. But on the lesser involved limb, you can see he already had an episode of DVT, which left him with extravasation of the tracer there. A wonderful article was written by Hisako Hara, which compares the lymphoscintigraphy with indocyanide green and correlates with clinical presentation too. Similarly, the ultrasound waveform information was pointed out by this great article by Shinichi Sakamoto. Now, all the lymphedema are with slightly different clinical presentation, and primary lymphedema occurs usually distally. And I want to point out this patient mainly for physical therapists, where you may consider, oh, okay, perhaps this could be a primary lymphedema, distal swelling, stem sign positive, and so on. Well, the patient had exquisite pain. And this is how initially it started without sensation of the pain, but it progressed to sharp pain. Lymphedema doesn't give you sharp pain and very exquisite pain. It gives you pain, heaviness, tension, and pressure. And at the end of the day, you may have a little bit more accumulation of the swelling. So this patient, we did ultrasound study, and on the right ankle, you can see the skin and subcutaneous space, which is a pretty much normal size. On the left ankle, it's completely different visualization of the skin, which is almost blending into subcutaneous tissue. And subcutaneous tissue is even in the muscle mass is different. So we sent her for further evaluation, and you can see just simple X-ray shows some abnormality, not only enlargement of the dorsal aspect of the foot with little gaps, and the MRI clearly confirmed the diagnosis of synovial sarcoma, which is it's fairly rare. However, it has to be treated immediately with hemato-oncology and maybe even radiation treatments. Another interesting patient, very slim young lady. Let me show you a little bit more about her. She's 56-year-old, administrative worker, 5'7" and only 115 pounds. And she complained of swelling for the past 20 years in distal lower extremity. When I examined her proximally, she had complete atrophy of proximal thighs, and she had a burn, old burn on the knee by getting herself warm, but putting hot pack to such a point that she didn't even feel that she burned herself. The tissue consistency was very soft, unlike you see in lymphedema. And further evaluation, when we did the ultrasound, what we found that in the skin is fairly thin, but you have these cobblestones floating in a fluid. The dark represents fluid, which this is not compatible with lymphedema. She unfortunately was bulimic, anorexic, and then some for all her life. So this is resulting from albumin deficiency, hypoalbuminemia, which fluid leaked out of the blood vessels into body tissue, resulting in edema. So this is edema. Typical prostate cancer patient with 40 lymph nodes involved. Unfortunately, he had 2 bouts of cancer, one recurrence, and the lymph nodes were removed. He received radiation treatments prior in 2013, and in 2016 he had a recurrence, so additional lymph nodes were removed, and again he had second bouts of radiation treatments and chemotherapy. Shortly after, he started to have swelling in both lower extremities, right more involved than left. And a lymphoscintigraphy points out that first 20 minutes, there is a very faint uptake in the left lower extremity, the lesser involved. And 3 hours later, there is a tortuosity of the channels, but we don't see any visualization of the lymph nodes. Well, we don't know how many lymph nodes he had prior to the prostate cancer. And we know he had many lymph nodes removed and radiated. So this is a clinical presentation correlation with lymphoscintigraphy. And this kind of patient has to be very vigilant about compression and conservative management, and avoiding any possibility of infections. This young boy, I told you he was bitten by mosquito. He was 11 years old. What was interesting about this young boy, this is how he appeared in a clinic. And he had white pustules oozing a whitish fluid. The MRI pointed out he had abnormal lymph nodes in the inguinal area, but also a higher periaortic lymph nodes too. And first lymphoscintigraphy showed on the uninvolved side, everything was perfect. He had inguinal lymph nodes. And I want to show you, and of course, 24 hours later, there was complete extravasation of the tracer to the involved side. But what was interesting for this lymphoscintigraphy is we injected only the sound leg, the good leg, and 3 hours later, there was seepage from the good side, from uninvolved side, to the involved leg. So there was, this was chylous reflux, where you have aberrant lymph system and direct connection of the lymph flowing into the involved left lower extremity. Complements of CT, the subcutaneous tissue enlargement. We call this honeycomb appearance in the subcutaneous tissue, typical for lymphedema, lymphatic studies. SPECT-CT radioactive tracer, the material is detected by the gamma arrays, and you can already see a tumor involvement. We also see a good number of patients with head and neck pathology, and on the MRI, you can see again the honeycomb appearance and on the involved site. And then we administer conservative management, lymphedema management for the head and neck. This slide is compliments of my dear friend, Professor Jean-Paul Delgado. And this is just a hand. And I want to show you the ICG. Oh, going back. See how the lymph collectors are opening up just by simple massage. And that is by injecting the indocyanide green into the lymphatic system, and you visualize actual lymph channels and propulsion of the lymph from the area of desired study. This I want to point out, what he did is down you can see a sleeve. This is for the upper extremity, and it is transparent, see-through. Therefore, they could visualize what is happening to the lymphatic system by just applying pressure from the compression pump. And here we can indicate that the pump treatment is really with high level of efficacy. See how the lymph collectors are opening up. And for the anniversary, I'm sharing my lymph to vein anastomosis. And you can see dilatation of the lymph channel. See this guy, and that's where the blockage was. And there is another one. Okay, from personal point of view, I can tell you I used to have enormous pain in my foot and my toe, fifth toe, and mainly at the end of the day after standing, even though I was wearing compression stockings all day. Now, look at the intervention.
So after the collection of it from here, then there was this channel that developed way back here around into the main channels here, and you can see the leg is spilling from this channel here. White.
After the surgery, it worked well, and I don't have the pain. So we do have the lymphoscintigraphy, but lymphoscintigraphy is not as precise in visualization what is really happening to the lymph channels. Two wonderful studies were done by Rasmussen and my friend Aldrich, and another study comparing the lymphoscintigraphy indocyanide green evaluation. A very unique patient, we don't see as many. This is Klippel-Trenaunay-Weber syndrome. It is a congenital anomaly with abnormal development of not only blood vessels, soft tissue, bones. You can see the fingers and toes are different shapes and sizes, and mainly lymphatic system. Very difficult, challenging. One of our patients, before and after conservative management, she had ovarian cancer, adenectomy, but you can see fairly symmetrical lower extremity enlargement. Initially, she had lipedema combined with lymphatic insufficiency, but with combination of the conservative management and patient's compliance, you can improve. My colleague showed that in their center, they are seeing phlebolymphedema predominantly. So what is phlebolymphedema? It is combination of the lymphatic insufficiency and chronic venous insufficiency. And you can see the varicosity and distal changes, distal lower extremity changes in the skin, and lymphedema, right lower extremity more involved than left, typically in all other slides. This I wanted to show you. I started a residency in surgery, and it was interesting that way back when we were instructed to do this fast by removing the saphenous vein. Along with that, there was a damage to the lymph channels too. And patient ended up with saphenous vein transfer to the heart vessels. Heart was pumping well, but the patient developed complications of the lower extremity swelling following this surgical intervention. So fortunately, we are not doing this technique anymore. Different types of swelling. What is lipedema? Lipedema is lymphatic microvascular disease and has pathological accumulation of subcutaneous adipose tissue. And typically you see someone with slim waist or slimmer waist and bilateral disproportional volume increase in lower extremity with symmetrical enlargement. And in later on, you can see the enlargement in upper extremity as well. Frequently, these patients are misdiagnosed. And even though they are not enjoying diet as much, they are frequently referred to see someone or stop eating so much. I remember a patient who came to see me from West, and the report from a physician stated, let's face it, she is the one who is putting food to her mouth. That patient was on 850 calorie diet for 1 month and was able to lose weight, waist up, but lower extremity enlargement persisted. So lipedema is a disease of loose connective tissue, but mainly there is excess of fibrotic connective tissue. And a fluid is bound to glycosaminoglycan within the extracellular matrix. Typical presentation of lower extremity lipedema with progression and complications. I want to point out that this patient had melanoma surgery before she blossomed and increased weight, and this horrendous defect left her with a very poor quality of life. Lipedema occurs almost exclusively in women. And as I said, there is bilateral and symmetrical volume increase in lower body and stops by the ankles. The feet are spared. The patient are experiencing heaviness, tension, tenderness on pressure, and pain to touch. Stemmer sign is usually negative unless it progresses. And there is increased vascular fragility with easy bruising. Arms are affected about 80% of time. And swelling worsens in hot climate and during summer. And it's very poorly affected by caloric restriction. What are the staging? As you see, it is bilateral and fairly symmetrical distribution, and waist is very slim. Stage 1, with progression to stage 2. Stage 1 skin is still smooth, and you can start feeling some, we call it little pearls, under the skin in subcutaneous tissue. Stage 2, with progression to lobes. At the knee, if you look at the knee, it is already covered by adipose tissue with many folds with progression. And very difficult quality of life and mobility issue. From the type, here is type 1, where is only the upper thigh region involved and buttock. Lower down, type 2, type 3, all the way down to the ankles. Type 4, arms, as well as on this picture, I am showing also a combination. And type 5, I only had one patient, and you can see how slim she was, but she had difficulty to fit into her boots because from the knee down, there was enlargement. Yes, indeed, that was lipedema. Combination of lymphoscintigraphy shows that the anatomy of the lymphatic system is there. A study was done where popliteal lymph nodes, which are not normal, are frequently seen in lipedema patients, and the lymph channels are dilated. Correlation of clinical presentation and lymphoscintigraphy. Again, this patient, first slide, this is normal lymphoscintigraphy. Stage 2 patient. Now you can appreciate the popliteal lymph nodes. Stage 3, also some lymph nodes. And another patient. So the anatomy of the lymphatic system is there. How the lymphatic system behaves is different. Different clinical presentation of lipedema patient with progression. On the clinical presentation, when you look at the eyelids, all lipedema patients have beautiful wide eyes. This represents a lot of inflammation and allergic reaction. Frenulum is frequently missing. It's just loose connective tissue disease. And look how you can slide the skin on the top of the skull, which is so typical for lipedema patient. And it was documented with chauffeur and as a hyperplasia of subcutaneous adipose tissue in lipedema patients. Hypermobility of joints present, and look what happens to the center of gravity. There is a complete shift. The anterior bowing of the thigh with the gluteal region, and frequently they have pronation of the feet. I think I'll show you later on. In the medial aspect of the thigh region, it's significantly enlarged. And Solnoky pointed out that there is a capillary fragility in lipedema patients, and you can appreciate this on this slide. Complications, genu-valgum. When you ask them to stand up straight, what they cannot, they have to be with feet apart because of genu-valgum, pronation of the feet, and involvement of the arm, which gives rise to the neck pain, upper back pain, and you can see the discrepancy of the waist to hip ratio. And frequently we see hyperlordosis because of the increase of gluteal region. A lymphoscintigraphy compared with clinical presentation and near infrared fluoroscopy, and you can see the dilated lymph collectors. And I like to use, and thank you, Jobst, for this wonderful diagram. With the ultrasound, we are studying the skin and subcutaneous space. And what holds together is the subcutaneous superficial fascia, which is connective tissue, and it is very strong, and it should not be disconnected. However, in lipedema patient, even the skin, because it's overstretched, there are little vacuoles, and subcutaneous fascia is interrupted. And way back when, I called it dancing fascia. And in lipedema patients, this is what we see on ultrasound study. And I'll go through some interesting case presentation. I'll show you a 23-year-old female. She came with a spontaneous swelling of the left ankle, foot, and toes, with more tension, pressure, and heaviness left more than right lower extremity. Well, further diagnosis led us to what I'll show you, May-Turner syndrome. And May-Turner syndrome is the left common iliac vein compressed by right common iliac artery. And a typical treatment is stenting. So you put a stent into the involved area, and this was 50% obliteration prior, and after it was nicely open. In addition to that, the patient also had positional pain in the pelvic region. Lymphoscintigraphy again points out that she had lesser number of lymph nodes on the involved left lower extremity with dermal backflow. And on venous study, she also had aberrant ovarian vein, which gave her rise to all the symptoms in addition. So she had low extremity heaviness, tension. She had pain to touch. She had easy bruising, fatigue, IBS, abdominal and pelvic pain. So she had combination of all these symptoms correlating with lymphatic insufficiency and also venous insufficiency. On the clinical presentation, she had one leg more involved than the other, congestive tissue consistency. And in lipedema patients, when you touch them, this tissue consistency is so soft, so squishy, and painful to touch on most instances. Okay, stemmer was positive only on the left, and fullness in upper thighs and hips were present bilaterally. Again, when we do evaluation on ultrasound, we are concerned about skin and subcutaneous tissue and the muscle. Now, with this patient, on the involved side, on the left side, she had increased subcutaneous space, and you can see the subcutaneous fascia was interrupted, dancing fascia. And on the right, there was the discrepancy. The involvement was much less than on the left. So complete diagnosis was May-Turner syndrome, primary or congenital lymphedema left lower extremity, which correlates with the lymphoscintigraphy finding that she had lesser number of lymph nodes in the inguinal area, lipedema, and also pelvic congestion syndrome confirmed by our study. Now, what does lymphedema and lipedema look like on ultrasound study? Lymphedema has thicker skin, and subcutaneous space is involved. But in lymphedema, the fascia is not so interrupted as you can see in lipedema. Lipedema skin is much thinner. Subcutaneous space is larger, and the fascia is either interrupted or it's almost like a cheesecloth when you stretch this. And in comparison to control, you can see skin very nicely, subcutaneous fascia, one straight line, and subcutaneous space. And so there is clear difference which we can point out just with simple ultrasonography, a non-invasive and fairly inexpensive test. And this was published way back when with Dr. Patel and our team. For lipedema patients, yes, there is poor quality of life when it progresses and so on. However, it doesn't have to progress as rapidly. This lady is 60-year-old. She has a wellness center, and clinically, you almost cannot detect that she has lipedema. However, she brews easily. She has IBS. She has symmetrical, small and expansion of the volume comparison to the waistline. Medial aspect of the knees are there, and a little pain to touch. A correlation with ultrasonography shows she is 60 and she's still just stage 1, but stage 1 and type 4. Another interesting aspect of when does lipedema start? It usually starts with the onset of puberty. And this young girl at the age of 12, with the onset of hormonal changes, just blossomed. At the age of 14, you can see the clinical presentation, and the ultrasonography already shows overstretched skin and subcutaneous space enlargement with interrupted or densing fascia in subcutaneous space. At the age of 15, she progressed. And at the age of 15, she started to participate in cross-country running for 3 months. And look at the difference, not only in clinical presentation, but also the ultrasonography. She improved subcutaneous space, was reduced by 43%. So exercise is the key. Now, what kind of treatment modality we have? For lymphedema, conservative management and surgical management. And conservative management, you can do the MLD, CDP, intermittent pneumatic compression therapy, any type of compression, bandaging, compression garments, vibration plate. The most important thing is activity, exercise, walking, swimming. Aquatic therapy is advisable. For surgical management, we have, as I pointed out, lymph to vein anastomosis or lymph node transfer. And that has to be done by well-qualified microscopic plastic surgeon knowledgeable in the field of lymphology. For lipedema, similarly, conservative management first and then surgical management. From surgical management, there are different types of surgical aspiration. And again, the patient, what we recommend is trial of conservative management and compliance. Just conservative management alone is not going to be beneficial. A wonderful study was done by Dr. Karen Herbst and her team, where they showed in improvement after liposuction in 84% of pain reduction, improvement of quality of life, 84% improvement of a pain, 86%, and ambulation improved in 96%. Of course, you can move easily with lesser volume. Few aspects of manual lymph drainage, bandaging, and compression pump treatment. Different modalities, different compression garments, and the compression garments should be well fitted and should not be too restrictive. You have to, especially physical therapists and or fitters, you have to be concerned with quality of life as well. And this Velcro compression is very beneficial. Aquatic therapy, bicycling is excellent, but keep moving. I want to point out about a lymphedema and lipedema nutrition guide for lymphedema and lipedema patients, which is very beneficial to go through, and lymphatic MPFF formula, which helps to reduce the swelling and improve permeability of lymphedema and lipedema patients. Well, with that, I want to open the questionnaires. This is interesting. Thank you, Andrea, for pointing this out. What we usually do is when the patient is scheduled for knee replacement, we do conservative management first. And compression therapy is very beneficial. And once we reduce the swelling to the maximum point of improvement, and then the patient goes and has a knee replacement. I would go for second opinion. You are only 38 years old, and to have a total knee replacement at this point, I'm not quite sure. But I would try to have second opinion. Okay. Oh, any location in Boston? No, I don't know the area in Boston. I am in Santa Monica, so I know the surgeon in our area and all the referrals that I get and the communication with our surgeons. And we have top of the top right here in Santa Monica. So if you feel like you can make a trip, we'll be happy to see you there.
I would like to interrupt for a second on the LEARN page. They can look at the centers of excellence. There's the Boston Lymphatic Center, which is a LEARN Center of Excellence in Boston. So Adrian, if you can look on, or we'll post the link to the Center of Excellence, LEARN Centers of Excellence, and people can see where there are different centers of excellence across the United States.
Okay. What do you think about keto and inflammation for the inflammation for Kathy? Okay, let me answer very quickly. Keto diet, you know, there are so many different diets for lipedema, and definitely it's worthwhile to try keto diet. However, one has to be very careful. I had a patient who was over 1 month on keto diet and developed kidney problems. So you have to make sure that you don't have any other ongoing problems for the keto. Okay. I'm sorry. My breast oncologist told me not to bother with compression pump. Do you believe? Okay, interesting questions. My breast oncologist told me not to bother with a compression pump. Do you believe? Are they helpful? Okay, I showed you compression pump works, okay? And it, if there is a stagnation, even in stage 0, where there is not arm width discrepancy or circumferential discrepancy, you may have stagnation or delayed transport capacity. So before jumping into a pump, I would say even though you don't have lymphedema, do gentle self-massage, self-manual lymph stimulation, and you can use compression pump, compression garment. But again, compression garment should not be very tight. It should be snug, and it should not create any kind of a tourniquet effect. So I would do that first before I would go into a pump. And it said when the oncologist said not to bother, well, the oncologist should work with physical therapist or occupational therapist and send patients for lymphatic stimulation first. Okay. So we are done. Are you accepting new patient? Yes, yes, I'm accepting new patient. Yes. Is there a preferred diet? Well, you know what? That's an interesting question. It's not a secret. I have been living with lymphedema for the past 40 years. I never overeat. That's a key. And I'm careful what I eat, but I'm not obsessed about eating just lettuce and tomato. And I eat pretty much everything, but I recommend a good diet and nothing processed foods, fresh vegetables, fresh fruits. And for lipedema patients, I recommend allergy testing. A lot of lipedema patients are highly sensitive to histamine-rich diets. And if you have any allergy for histamine-rich foods, go through and online you can find histamine-rich foods and try to eliminate that. And that will be the best. So from the diet, preferred diet, probably the best is Mediterranean diet, but never overeat. Eat small portions and eat healthy. Is liposuction appropriate for arm lymphedema? You know what? Absolutely, yes. Liposuction started with Dr. Brorson, Hakan Brorson, my dear friend in Malmo, and a lot of our surgeons even went there to learn that technique, and it is beneficial for lymphedema. But again, you have to go to someone who is very knowledgeable and who has done this type of surgeries. In terms of lipedema, I had one patient who wanted to have a shortcut and went to someone who didn't know anything about lipedema. However, she had liposuction done and the outcome was very unpleasing. So it's important to go to the best. Okay. At what stage do they perform CT scan? You can, you know, if it's medically necessary, you should have a CT scan whenever it's medically necessary. What type of surgeon do you look for if there is no lymphedema doctors in the area? Well, you know what, this is a very interesting question. Go to the area where there are lymphedema doctors. Don't go to someone who never operated on lymphedema before, because it is not, it's a different type of field and you have to go to the best to have the good result. On the last slide, I showed a micronized, purified lymphatic formula, and you can buy this on Amazon. This was researched out by Dr. Monica Glovitsky, fantastic surgeon, vascular surgeon, and it took 15 years, and it was not only on the animal study, but on human as well. And I see wonderful results in volume reduction and a reduction of pain. Actually, we did some study on that, and it's called Lymphatic Formula 1000. Okay, a very interesting question. Thank you for asking this. Young lady with a lymphedema precox, had some complication. Now she's 54. At what stage do we think ultrasound is necessary or a baseline lymphoscintigraphy? Well, I tell you, if you are doing well and you are managing without any complications, if you are ever in Santa Monica, stop by, I will do the ultrasound. Ultrasound is non-invasive and not very expensive. Lymphoscintigraphy, if you have good insurance and Medicare pays for that, you can have that done. And is it medically necessary? If you are doing fine, you don't need lymphoscintigraphy. Interestingly, it correlates with clinical presentation. And I had one young man just recently where only few lymph nodes were missing from the inguinal area, yet he was born with one swollen leg. He is doing so well that I, with conservative management and self-care and not overeating, he can skip any kind of further study, but come back for periodic treatments. Okay. I don't understand this. Yes, I do all those things and I have lymphedema. My dear, I can totally understand because I live with lymphedema. And way back when I somewhere said lymphedema embraced me and I embrace lymphedema. I live with that. Lymphedema will not go away. And what is interesting, most of the patients would come for a treatment and the question was, can you fix this? No, we cannot fix this. We can improve. And with compliance and conservative management, you can have fairly good life. Okay, I take two more questions, okay? Okay, a very interesting question from Jackie. Thank you so much for asking. She developed full-blown lymphedema in December. One needs to know why. Lymphedema just does not appear. There must have been some either surgical intervention or something. And is it primary, secondary? One needs to know. And she started the treatment, and then she had lymphocellulitis, and then she developed blisters under compression wraps. So this is so important. We recommend compression wraps, and according to whatever teaching, compression wrap should be on for 2-3 days for as long as you can. But if you have other issues like rheumatoid arthritis and so on, and peripheral neuropathy, you have to be careful when you are applying compression, any type of compression, and then you have to check this so you don't develop any blisters. So treat that first. And if you do compression and you are not comfortable, you just take it off. Don't struggle, don't suffer. All right, last question. You are doing, this is for Jennifer. Jennifer, I sympathize with you. Yes, you are doing all the treatments, and at the end of the day, you have very swollen leg. I guess it's lipedema. What else can I do? I pointed out, you know what, it depends what stage you are, and diet and exercises. If you can get to the swimming pool, move, and apply the compression stocking when the leg is dry, and make sure that in between toes you don't have any moisture, so you don't develop fungal infection. So it's compliance as well as going somewhere for treatment. Carol, last question. Is lipo covered by insurance? Somewhere in our area, some insurances started to pay. I think Blue Cross Blue Shield is one of them, but you have to be very diligent on talking with them, writing to them, be on the top of the case. They may not reimburse the whole thing, but they can contribute. And with that, I want to thank all of you, wonderful team, and happy anniversary, Lymphatic Education and Research Network. I still remember the old lymphatic education, not lymphatic education, that is a new name, Lymphatic Foundation. And I compliment the whole team for the enormous work and progression that you did in past 25 years. We still have a lot of work to do, teach the physicians mainly about lymphatic diseases and how to manage them and not to dismiss them. With that, I want to thank you very much. If you have any questions, feel free to call my office or email me, lowercase Iker at lymphedemacenter.com or 310-829-7472. Thank you.